Welcome to our comprehensive update on the psychopharmacology algorithm for post-traumatic stress disorder, or PTSD, for 2024-2025. Since the last major update in 2022, new research has reinforced and refined key recommendations for clinicians treating PTSD. This video will guide you through the latest evidence-based approaches, highlight changes in medication strategies, and discuss emerging treatment. Whether you're a healthcare professional or someone interested in mental health advancements, this update aims to clarify the most effective pharmacological options for PTSD, focusing on optimizing patient outcomes with the latest data. Updated PTSD algorithm is built on a rigorous review process. The team began by examining recent literature, following a systematic approach similar to previous Harvard South Shore program algorithms. This included a thorough review of studies published in the last 2 to 3 years, with consensus reached through peer review. The process ensures that only the most pertinent and validated evidence informs the recommendation. This methodical approach adds credibility and reliability to the algorithm, making it a trusted resource for clinicians navigating complex PTSD cases. Prazosin remains the cornerstone of pharmacological treatment for PTSD, especially for sleep disturbances like nightmares and disturbed awakenings. Recent meta-analyses have reinforced its effectiveness, making it the most recommended medication for both sleep and certain daytime PTSD symptoms. Notably, prazosin is also beneficial for patients with comorbid alcohol use disorder and headaches. Safety profile is well established, and some patients may require higher doses than previously cited, with case reports supporting doses up to 45 mg at bedtime. This flexibility allows clinicians to tailor treatment to individual needs. After managing sleep disturbances, attention shifts to persistent daytime PTSD symptoms. If significant symptoms remain, selective serotonin reuptake inhibitors, SSRIs like sertraline or paroxetine are recommended. These medications target mood, anxiety, and intrusive thoughts. If psychotic symptoms are present and do not respond to SSRIs, augmentation with an antipsychotic such as aripiprazole is considered. This stepwise approach ensures that each symptom cluster is addressed methodically, maximizing the chances of meaningful improvement for patients. If the initial SSRI trial is unsatisfactory, the algorithm suggests trying a second SSRI or a selective norepinephrine reuptake inhibitor (SNRI). However, it's important to note that SNRIs do not offer significant benefits for hyperarousal symptoms. For residual daytime symptoms, prazosin may be considered again. This flexible, evidence-informed approach allows clinicians to adapt treatment plans based on individual patient responses and tolerability, ensuring that each step is grounded in the latest research. Update also explores several emerging treatments for PTSD, including transcranial magnetic stimulation (TMS), direct current stimulation (TDCS), stellate ganglion block, and pimavanserin. While these interventions show promise in early studies, the current evidence is not yet strong enough to warrant their inclusion in the core algorithm. Ongoing research is closely monitoring their efficacy and safety, and future updates may incorporate these options as more data become available. 2022 algorithm, depicted in a flowchart, begins with confirming a PTSD diagnosis and evaluating comorbidities such as bipolar disorder, psychosis, substance dependence, and pregnancy. The initial focus is on improving sleep quality, which can reduce daytime symptoms. If sleep issues are resolved but daytime symptoms persist, SSRIs are introduced, followed by possible augmentation with antipsychotics. Additional trials with other antidepressants or prazosin for daytime use are considered for treatment-resistant cases. This structured approach ensures that each patient receives a tailored, stepwise treatment plan. Comorbid alcohol use disorder (AUD) is common in PTSD patients and can complicate treatment. While doxazosin was previously considered as an alternative to prazosin due to its longer half-life, recent studies have shown it is not more effective than placebo for general PTSD symptoms. Prazosin, on the other hand, has demonstrated benefits for both PTSD and alcohol use outcomes, especially in patients who use alcohol to self-medicate. This reinforces prazosin's role as the preferred option in this population. Multiple recent meta-analyses have confirmed prazosin's effectiveness for PTSD, even after considering large studies that initially questioned its efficacy. Prazosin stands out as perhaps the best pharmacotherapy for PTSD, with benefits extending to both sleep and daytime symptoms. It has also shown promise in reducing alcohol cravings and depressive symptoms in patients with comorbid PTSD and AUD, particularly those with elevated blood pressure. These findings support the concept of an adrenergic subtype of PTSD that responds well to prazosin. While prazosin is the primary medication for PTSD-related nightmares, other drugs like ciproheptadine and mirtazapine have been used, though controlled studies are lacking. Mirtazapine may be considered for general PTSD symptoms, but its efficacy for nightmares is not well established. The algorithm prioritizes treatments with the strongest evidence, so prazosin remains the preferred choice for sleep-related symptoms in PTSD. Patients who use alcohol to self-medicate PTSD symptoms, prazosin may help reduce their perceived need for alcohol. A small randomized trial found that combining prazosin with naltrexone provided additional benefits for alcohol use outcomes compared to naltrexone alone. This suggests that prazosin not only addresses PTSD symptoms, but also supports recovery from alcohol dependence, offering a dual benefit for this challenging patient group. Transcranial magnetic stimulation (TMS) and its variants have been studied further in recent years, showing modest benefits for PTSD. A meta-analysis found a significant reduction in PTSD symptoms using high-frequency TMS over the right dorsolateral prefrontal cortex. However, optimal treatment parameters are still being determined, and more research is needed before these techniques can be fully integrated into the core algorithm. Recent studies have also highlighted prazosin's effectiveness in reducing headache symptoms related to mild traumatic brain injury in PTSD patients. This expands its utility beyond sleep and general PTSD symptoms, making it a versatile option for clinicians managing complex cases with overlapping symptoms such as headaches. Anxiety is a hallmark of PTSD, but clinicians sometimes misattribute it to other disorders like panic or generalized anxiety disorder. The update recommends considering prazosin first for anxiety symptoms in PTSD, as medications like benzodiazepines, gabapentin, or busburn have not shown effectiveness for PTSD-related anxiety. Careful evaluation is crucial to avoid misdiagnosis and ensure that patients receive the most appropriate treatment. Direct current stimulation, TDCS, is a novel neuromodulation technique that has been combined with virtual reality exposure for PTSD treatment. A recent randomized trial showed increasing efficacy over 3 months, but quality of life did not improve and dropout rates were high. While promising, TDCS requires further research before it can be recommended as a standard treatment for PTSD. Remains unclear how neuromodulation protocols like TMS and TDCS should be integrated with pharmacotherapy, since only medications that lower the seizure threshold are contraindicated with TMS, and these are not part of the current algorithm. Future research may justify combining these approaches. For now, clinicians are advised to monitor ongoing studies and await stronger evidence before routinely using neuromodulation alongside medication. Older adults with PTSD often tolerate prazosin well. A retrospective review of veterans with an average age of 70 found significant improvements in nightmares without significant changes in blood pressure. This supports the use of prazosin in older populations, expanding its applicability across age groups and providing reassurance about its safety profile. Stellate ganglion block has generated interest as a potential treatment for PTSD, but no new randomized trials have been published recently. Researchers continue to monitor this area closely, as future studies may provide the evidence needed to consider it as a viable option in the PTSD treatment algorithm. Pimavanserin, a selective 5-HT2A partial agonist-antagonist, has shown promise in small case series for improving sleep quality and latency in veterans with PTSD-related insomnia. However, more robust evidence is needed before it can be included in the algorithm. For now, prazosin remains the preferred option for insomnia associated with PTSD. Benzodiazepines are not recommended for treating insomnia in PTSD. Recent studies have shown that these medications can reduce the effectiveness of exposure-based psychotherapies, which are commonly used for PTSD. This further strengthens the recommendation to avoid benzodiazepines in this population, emphasizing the importance of evidence-based alternatives. Although the algorithm is not intended for children and adolescents, prazosin has been used for nightmares in younger populations with some reported effectiveness. Clinicians should exercise caution and rely on emerging evidence when considering pharmacological interventions for pediatric PTSD, as research in this area is still limited. It's important to note that the PTSD psychopharmacology algorithm focuses exclusively on medication management. It does not compare the effectiveness of pharmacotherapy to other modalities, such as psychotherapy. The algorithm is intended to assist clinicians in selecting medications when pharmacological treatment is chosen, but it does not address when to start or combine with psychotherapeutic approaches. Updated algorithm is grounded in the latest and most robust evidence available. By systematically reviewing new studies and incorporating peer-reviewed consensus, the recommendations provide clinicians with a reliable, up-to-date guide for managing PTSD pharmacologically. This evidence-based approach ensures that patient care is optimized according to the most current scientific understanding. One of the strengths of the updated algorithm is its flexibility. It allows clinicians to tailor treatment plans based on individual patient needs, comorbidities, and responses to previous interventions. By providing clear guidance on when to switch or augment medications, the algorithm supports personalized care and better patient outcomes. Safety remains a top priority in PTSD pharmacotherapy. The algorithm emphasizes monitoring for side effects, especially when using higher doses of medications like prazosin. Regular follow-up and patient education are essential to ensure safe and effective treatment, particularly in populations with complex medical histories or multiple comorbidities. The field of PTSD treatment is rapidly evolving. Ongoing research into neuromodulation, novel pharmacological agents, and combined therapies will likely shape future updates to the algorithm. Clinicians are encouraged to stay informed about new developments and to consider enrolling patients in clinical trials when appropriate, contributing to the growing body of evidence. Effective PTSD management often requires collaboration among healthcare providers, including psychiatrists, primary care physicians, and therapists. The updated algorithm serves as a common framework, facilitating communication and coordinated care. This team-based approach enhances treatment adherence and supports comprehensive recovery for patients. Educating patients about their treatment options, expected outcomes, and potential side effects is crucial for successful PTSD management. Empowered patients are more likely to adhere to treatment plans and engage actively in their recovery. The algorithm encourages clinicians to involve patients in decision-making and to provide clear, accessible information throughout the treatment process. Summarize, the 2024-2025 PTSD psychopharmacology algorithm update reinforces prazosin as the first-line treatment for sleep and certain daytime symptoms, clarifies the limited role of alternatives like doxazosin, and highlights emerging but not yet recommended therapies. The algorithm remains flexible, evidence-based, and focused on optimizing patient outcomes through individualized care. As research continues and new treatments emerge, future updates to the PTSD algorithm will further refine and expand available options. Clinicians are encouraged to stay engaged with the latest literature and to apply these evidence-based recommendations in their practice. Together, we can continue to improve the lives of those affected by PTSD.